America's favorite video series, don't fact check this, is now a podcast. In Collaborative Corner, Dr. Mark Blumenstein breaks down important issues in collaborative eye care. Listen to each new episode starting in January as he reviews the optometrist's role in managing a patient's eye care journey. Tune in through your preferred podcast player.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Jessilin, what's up?
Hello, and hello to all of our listeners. I don't know about you, but I am stumped because I keep looking at this date and I'm like, summer is over. We are moving into fall, and then comes winter, and that's like the peak of dry eye season. So I'm like, we're about to get busier.
I know. You know what? There's a lot of patients in my clinic where we're prepping for winter by like either doing a tear care or some thermal expression or an IPL before to try to like set them up for success in winter. I don't know if you're finding that too, Jessilin.
Definitely prep as much as we can, for sure.
We have a great person to actually talk to on the podcast tonight, and I was looking through my notes trying to find when I actually wrote down on my to-do list to have Jason on the podcast, and I couldn't find it, but we think it might be the year 2023, which unfortunately is sometimes when I actually 2 years later will check things off my to-do list. But audience, listeners, we're so happy to have Dr. Jason Besecker on the podcast tonight because Jason has done what many of us talk about doing, and many of our listeners ask us, how do you build a dry eye only clinic? So we're so pumped to talk to Jason. Jason actually has a really interesting background. So first of all, he's the only person I know from Idaho. Okay, so like he was born and raised in Idaho. I don't know anybody else except for Jason. He went to Indiana University School of Optometry, and then for 7 years he worked at an OD/MD group practice where he's, really seeing a lot of like high level ocular disease and gets, obviously as we all kind of do in these settings, get very comfortable, treating this variety of ocular disease patients. And then I think we're gonna talk to him and find out. But I think you saw a need, right, of people who need more specialty dry eye care that either you weren't able to provide or you were seeing not being the need not being met. And so 4 years ago he opened a dry eye only practice, and it's the same name as my office. And so we're already together by that. We both have an Envision practice. So we're so happy to talk to you tonight, Jason. Thank you so much for being here. You all have probably seen Jason. He's on the podium. He's lecturing about dry eye. He's writing about dry eye. And now he's made some time for us to talk about dry eye. So welcome, Jason. Thank you for coming. Thank you for being here.
Oh my gosh, thank you so much for inviting me, Jackie, Jessilin. You guys have built such an amazing platform. You have the best people on here. Then you decided to have me on here. Hopefully I don't ruin your reputation there. No, it's such an honor. It's such an honor to be here. And I don't think I named my clinic after yours. Maybe subconsciously I did. I don't know if you had yours beforehand. But great name.
I know it is a great name. I didn't name it either. I bought it with that name, so I didn't name it either. But I think, we're connected in that way, that we have the same practice name. It's wonderful.
I love it. Jason, you and I had first met. I had given a lecture and you came up to me afterwards and you were just so kind and so genuine. And I just really remember that first encounter when I met you, and you are just such a kind soul, right? And you're just so gentle and authentic. And I love that for our profession, but I know that your patients must really admire that too. And I think sometimes with dry eye, it takes a listening ear, right? And so I knew straight out the gate that there was something very special about you because of just how that first kind of meeting was. So So it's been nothing but positivity from that point out. And I was trying to think when that was. I think it's been a couple of years, but I'm glad that you were
Yeah, I
finally
think it was
on.
at I think it was at Seco a few years ago, I
Yeah,
believe, if I remember
that's right.
correctly. Yeah. Yeah, well,
Time
thank you.
flies.
I appreciate that. You're right. It does take a special touch, I think, with a lot of dry eye patients. As we know, there's a lot of mental health conditions that kind of go hand in hand with dry eye. And sometimes I wonder, is it the chicken or the egg? Did the depression come first and then the medications led to dry eye? Or did their dry eye lead to depression? Because we know how much it can consume a patient's thoughts when all day they're just thinking about their eyes, they're feeling their eyes, and that can be very depressing.
That's so true. I always think it's interesting, on like a lot of like Facebook groups, there's whole groups committed to, from the patient perspective, like these dry eye communities where they talk about their symptoms. And so I always think it's good for us to keep tabs on that, right? So I like to read through those as just like a real reminder of the how impactful the quality of life, the impact that can have for dry eye. So sometimes when we're even in the thick of it, we can sometimes almost get a little bit kind of numb to some of that, and it's a good perspective. But you're exactly right.
I agree. That's a very good point. I think it's easy to forget how much this might be affecting their quality of life, because we do hear these a lot, and sometimes I think how patients portray it, they might even be downplaying it a little bit. And yeah, I think it's important to step back and think, well, how might this be affecting my patients, their quality of life, their activities of daily living, which ultimately that's what we want to be improving, right? We want to improve their quality of life. We want to enhance their activities of daily living. And I think there's many ways we can help, not only in just dry eye, but in all these different areas of optometry. I think it's I think we're at a really cool point in optometry these days with all the new diagnostics and treatment modalities, not only for dry eye, but myopia control. We look at all that, even presbyopia now, specialty contact lenses, vision therapy, sports vision, low vision. There's all these areas that we can decide, hey, I really like this area. This is what really fuels me about optometry, is this specific area, and then just develop a passion for that. I hear many people talk about finding their passion, and if I was trying to find my passion still, I would probably still be looking. I realized I enjoyed dry eye. I enjoyed helping the patients and helping people find relief. And then over several years, I developed a passion for it. I just read profusely about it, watched every webinar I could. It was during the time that Dr. Art Epstein was doing his dry eye masterclass, which was amazing. He helped really drive a lot of the things that I do now and helped me just develop that passion. And now dry eye, it's I'm having more fun now than I have my entire life, is what I tell people. I love optometry. I always have, but it's even more fun now than it's ever been.
So walk us through like that journey. I mean, I hear that you have, and we see certainly that you have this, passion for excellent patient care and passion for dry eye. How did you make that move between, being an associate in an ODMD practice to saying, you know what, I'm going to start my own dry eye clinic. Talk about a little bit about that.
Yeah, that's a great question. I don't know if we have enough time to get through all of that today. It kind of like what you were saying at the beginning. I was working in a ODMD clinic, doing a lot of cataract and LASIK pre-op, post-op, and as we know, cataract and LASIK can create dry eye. So I was seeing a lot of dry eye in the clinic from that, and elderly people end up having dry eye, and that's who's getting cataract surgery most of the time. So I was inundated with a lot of patients with dry eye, and I used to be the doctor that would run away from dry eye patients. I really was. I was like, oh my gosh, another one. Oh, I can't do anything for him. Nothing works. I don't have options. And I started, looking more into it. I started doing the Art Epstein dry eye master classes, And every time I opened up my email, there was something new about dry eye. That was right around the time where Zydra had just been released, not too long before, where before all we had was Restasis. Lipiflow had been around for a little bit of time. IPL started gaining a little bit of traction, hearing more about IPL. So I was thinking, wow, we actually have more options, more diagnostics. And I just started looking more and more into it, started incorporating some of these things in the clinic that I was currently at, start seeing people get a little bit better, spending more time with my patients, even with the basics, with the hot compress, lid hygiene, triglyceride based fish oil supplement, taking the time to talk to them about those and seeing people getting a little bit better. And then also how appreciative people are when you take the time to listen to them and try to help them. And I really started enjoying it more and more and kept diving more and more into it. And then thought, hey, let's bring some of these bigger modalities into our clinic. So I was speaking with the owners and they said, no, our jam here is LASIK and cataracts, which I appreciate. That's like, this is what we do. And they said, well, we'll let somebody else do that. And little did they know I was going to be the person that did that. And I started just asking people, running numbers to see, is it a viable thing? Because at that point in time, I couldn't find anybody that had a dry eye only clinic, and that's all they were doing. I saw many people with a dry eye specialty clinic within their primary care clinic, but nobody doing just dry eye. And I start running numbers, and it looks like, yeah, it could work. There's definitely this could work. And I start asking people that are higher up in the industry that had dry eye clinics themselves within their primary care, and hands down, the answer I heard from everybody was it can't be done. That's hands down is what I heard, and the reason always was because I was based off referrals, is how my clinic is, how I initially would get my patients, was based off referrals from other optometrists, and everyone told me optometrists don't refer to optometrists. And luckily, I think some don't, but luckily many do, because that's how I was able to build my clinic, is referrals from other doctors who saw what I was doing, how it could benefit their patients by sending them to me. I manage their dry eye and then get them back to those doctors for anything else that they might be managing, whether it be glaucoma, mac degen, primary care, contacts, glasses. I send back to that optometrist to do everything that they do, and it's worked out very well.
That's awesome. How, when you started kind of initially building and forming those connections, how did you market yourself, right? Was it just with ODs? What strategies did you use? Did you go to other specialties? Looking back, would you do anything differently, I guess, in hindsight?
Yeah, that's a good question. Mainly ODs and OMDs was my main target. And I would just show up. I just show up at their clinic. I have a little marketing packet that had a lot of little trifolds of different diagnostics or treatments that I have. So they would have an idea of how what I'm doing might be a little bit different than what they could do for their patient. And then explain to them all these different things that I have and how I can help them help their patients, and maybe even relieve a little burden um, off of them and their chair time, because many of these patients, as you guys are probably aware, they just keep showing up, and then eventually what they do is they show up at somebody else's clinic because you haven't been able to do anything to help them, and so then they go somewhere else, and then they do the same thing there. So I feel I provide an avenue for these referring doctors to help relieve some of their chair time too. Not like, oh my gosh, God, Mrs. Jones again. This is the sixth time this year she's been here, and it's only February. It's like, I can't do anything to help her. So to help other doctors as well, relieve some of that burden on their chair time.
I think you totally said. I mean, there are certainly doctors who don't want to do anything with dry eye. I was this. I mean, similar to you, I was one of those. Before when I had other, sort of things on my plate, an insane schedule. I didn't have the time really, and I was sort of like, oh my gosh, the longer I'm with you talking about dry eye, the more behind that I get. So I certainly think that there is that group of doctors who would like someone to help manage. And I think some of the fear, and you sort of pinpoint, is like, ugh, ODs don't refer to ODs, or that was what you were told. I don't think that that's true either. I'm lucky enough that I have some ODs that, trust me, with their patients. And I'm always very grateful that they do. But I also have an optical, right? And I think that has been some of the mindset of OD to OD referral is you're going to try to swoop my optical sales when this patient comes in. And I think that there comes some level of trust with the doctor that's referring to you and the relationship that you've established. And I, hope my referring doctors understand that I don't want this glasses sale. This is not why we're here. I am here for the dry eye patient. And I think that does take some relationship building with you and the referring doctor. I think from what I hear from a lot of our colleagues is like, can you really do it? And even, maybe this is actually my question. Can you even do it without an optical? An optical still makes up a decent part of my revenue. And have you found that to be sustainable while not having that and just doing just a dry eye only? You and I have spoken a little bit about this, years ago, but do you feel like that you still feel strongly like this is a viable, practice option for patients, and it's just not as considered as it maybe should be with our colleagues?
That's a great question. I sure hope it's a viable option because it's my only option right now. So I really hope it is. No, it's been great so far. I make sure I have a lot of different treatment options that I can provide to patients, various cash pay options, but also insurance. I take a lot of insurance being referral based. I think I'm credentialed with 45 different medical insurance carriers. I don't want a barrier of, oh, I don't accept your insurance when somebody refers a patient over. I don't want that to be a barrier. So I just made sure I was credentialed with pretty much every insurance plan under the sun. That might have been a little bit of an overkill. Um, but then making sure any viable option for the patient that you find through your testing and your exam that you feel might help the patient, you provide these options to the patient, whether it be cash pay or insurance or both. And so I make sure I'm doing insurance-based procedures that can help patients. Procaras, plugs. We do conjunctivoplasty with a plasma pen as well, which you can bill to insurance. Making sure that you're billing those appropriately so you get reimbursed at the highest level that you can. Knowing about coding, and I really like the new coding and billing rules that we got. Oh, when did it start? 4 or 5 years ago, where they're time based. Many of my exams are based on time. Also, most of these patients have some form of medication prescription management that I'm doing, whether it be a steroid or XDEMVY or some type of immunomodulator. Now we have Triptyr. We have all these different prescription options. And if they have two chronic conditions and prescription management, that's a level 4 exam all day long, even if you were only with the patient for 5 minutes. And if you're coding correctly, all of your dry eye patients have more than one chronic condition. I mean, they all have meibomian gland dysfunction and anterior blepharitis at best, and those are two chronic conditions. And then if you have a prescription medication, that's a level 4 exam. So most of my exams are level 4 exams. Knowing how to use modifiers, and then providing the cash pay options to patients as well, and not being afraid to provide these options as well, and let them be the deciding factor on whether they want to make that investment into improving their comfort or not. And keep reiterating those when they come in. If they're doing the basics and they're maybe improved some, but they're like, man, I want to get better. Reiterating that, hey, we have all these other options. Some of them are cash pay, but these are the ones, my patients that are incorporating procedures into their treatment plan typically improve more so than the patients that are not. So just educating your patients accordingly as well.
I think you hit the nail on the head that to be viable, you really have to know the billing and coding part and the ins and outs. And sometimes that can direct like your flow, right? And I'm sure that that's probably evolved for you over, over your years. Like I feel like my dry eye flow has definitely evolved, and I'm sure you guys has too. And when I think about like when I have patients, of course, like I have some patients that are internally in a lot of our clinics, but like you get some referrals. And sometimes when those referrals come in, sometimes their biggest goal could be to improve their vision, right? And maybe it's not always that, maybe it's comfort issues. And sometimes when you get referrals, you might know their full medical or ocular history, and sometimes you don't, right? And I remember when I was first kind of getting like my flow going, it was sometimes you would just have this unknown person that even came in from a great outside provider, and you had no idea what was happening in the back part of the eye, right? And if you're a referral center, right, you're very much focused on the anterior segment and the dry eye portion. So looking back, has that changed? Like, have you brought in extra equipment? Do you require like the patient to have a full exam and have those chart notes from a referring doctor? How has that kind of evolved for you with your, kind of dry eye focus practice as it is now?
I think I'm similar to you, Jessilin. Is it's a constant state of flux. Try because I think it's important to always trying to do better, and sometimes just changing little things here and there can improve the flow, improve the outcome. So I've changed a lot from the beginning. At the beginning, I did everything. I didn't have a tech or scribe, so I was working patients up from the very beginning, doing the mybography and all that. We initially started with lower lid mybography. More recently, we're doing upper lid mybography as well, based on a paper. I don't know if you guys are familiar with the paper. It was in Cornea, I believe, at the very beginning of the year by Priya Gupta and Paul Karpecki, showing that the upper lid glands could be vastly different. I was under the impression like, oh, they're all probably very similar. And that's been proven not to be the case, especially in our contact lens wearers. They tend to have a lot more upper lid changes than lower lid. So I started utilizing that as well. I started off doing non-invasive tear breakup. Then I stopped doing it because I thought this does not correlate at all with my fluorescein tear breakup time. This makes no sense. So I stopped doing it. But then recently I started doing it again. Uh, got the Scout Pro, going to incorporate osmolarity. Big part of that is showing patients their improvements, I think helps them improve. I have found I'll have a patient come in, they will fill out their speed questionnaire because every exam they do a speed questionnaire. Fill out their speed questionnaire, and I'll look. I was like, oh, it's improving. But then you ask them directly, they're like, oh, I don't really feel like I'm doing any better. And then you start showing them, well, last time you filled out the symptom questionnaire, you were an 18 out of 28, and now you're a 10 out of 28, according to how you filled it out. So that's some improvement. And then showing them pictures. I record everything with a slit lamp camera, iRes. It's beautiful, really high quality. And you show them what their cornea looked like last time. Maybe they had 1+ PEK scattered across their surface, and then today they almost have none. And then you show them those pictures, and then you almost see a light bulb go off in their head. And then the next words will be, you know what? You're right. I am doing better. I think often the signs will improve before symptoms. So osmolarity, I'm getting it for that purpose. Be another thing I can show them. Hey, you were here before, now you're here. You are improving, encouraging them to continue on the treatment plan we're making improvements. This isn't for nothing. So I had recently incorporated that. Going to start doing non-invasive aesthesiometry with the Brill non-contact, figuring out how to work that into my flow. It'll be part of the workup that the techs do, just test corneal sensitivity as a baseline. I do, Jessilin, it's interesting you mentioned back of the eye. I started after a while doing baseline macular OCTs on my dry eye evals as well. Because you're right, you don't know what's going on in the back of the eye. Many of these patients, their chief complaint is going to be vision related, and they're referred over for dry eye because of their vision. And there was times where I would look at their eye, look at their complaint. I'm looking like, well, their vision complaint can't be due to their dry eye because they don't have PEK all through fixation. Their tear breakup is pretty solid. They got a good tear prism. Like, this doesn't look like a dry eye vision related problem. And then I would shoot an OCT at that point, and they would have an ERM or VMT or cystoid macular edema, which is causing their vision complaint. And so I've incorporated that as well to have that ruled out as a possibility. So I don't go through all these things going, what in the heck is going on here? And then shoot the OCT is like, oh, well, that's the problem. So yeah, there's just many things changing as far as diagnostics, procedures. We're constantly changing those as well. I'm considering LLLT. I don't know if either of you are doing low level light therapy right now. There's some better data now that shows that that could be beneficial. More recently got Blefx. Rinsada is amazing. I love Rinsada. I do a lot of Rinsada, especially those patients with really deep fornices. I think that works really well. So bringing that in, just always changing, always changing.
Yeah. I think that's what makes you such a good doctor, right? You're always, listen to you. You're like always learning and trying to learn more. And maybe I'm going to do this rhythm. And then now I'm not going to do, I feel the same about non-invasive tear breakup time. Like I was doing it and then now I'm not doing it. And then I'm like, is this reliable? Like, ugh. So I think that's what makes you such a great doctor to your patients is you're always, striving to have the best protocol for them. And that requires some, flux and some change with that. So I also feel like I was talking to, I think it was Jen Lyerly. I don't know if you guys know her, but she's wonderful. But I think I was talking to her years ago and she was like, treating dry eye is just like being a cheerleader. You have to be like, you're doing great. Like you're doing amazing. So you just need to that positive reassurance to the patient because sometimes they really don't know, but you're so right when you tell them like, oh my gosh, you look better. They're like, you know what? I thought so. And you're like, oh, okay, great. They just like they need you to say it. That's what I found a lot of dry eye is.
Absolutely. And I like that you brought up the different referrals because when we talk about it's really cool to be a standalone dry eye referral clinic, right? And obviously that takes a lot of work and a lot of nuance and some things that I don't think I would have thought about till I've been in it is like how do you navigate those patients where you have no idea what the back part of their eye, right? Like you have to set realistic vision goals with them. And how do you deal with those patients that like if you did have an optical, right? And, respecting and sending them back to the OD who referred to you to have their full exam, right? And sometimes even when you get those patients too, they're like, well, why didn't my optometrist do this, right? Or my eye doctor do this? And you have to navigate those in a very professional, I feel like delicate way, right? Because we're all on the same team. We want our patients to do best. And sometimes I feel like those are things in a business strategy that you don't necessarily think about when you sit down and like write a business plan and you're figuring out your flow. And that's why I love talking to people who have these standalone clinics, right? Because those kind of nuances pop up and just sharing ideas and just hearing about that so that as we encounter that, we can kind of tackle it and approach things differently. But also Jackie's exactly right. Being open and nimble and willing to learn and evolve and being a cheerleader is so important for dry eye and the community that we're in. If you had like one piece of advice to give anybody that was maybe wanting to start their kind of standalone dry eye clinic or even just get into the space, what would be your piece of advice for them?
Just do it. No.
Love it.
I think what has helped me along the way is the passion, is developing a passion for what you do. Because as you were saying, it's difficult. It's not always easy. There's been long hours. There's been a lot of headaches. But at the end of the day, if you truly believe in what you're doing, you're passionate about what you're doing, it makes jumping through all the hurdles a lot easier, and you don't get beat down from it because you know what your goal is, you know why you're doing it. You're not just doing it to make a dollar bill to pay the mortgage. You're doing it to provide value to people, to improve quality of life. And I think when it's more about other people than it is about you, I think that makes it easier to kind of dredge through and make it out the other side and not get beat down.
You are full of very useful and I think practical information on how to even build, how to build your standalone dry eye clinic. We always end this podcast with a life lens where we ask our guests to tell us something that is in their life that has made their life easier. They really appreciate, can be anything, does not have to be eye care related. What do you think? What about you? What's made your life easier? What do you totally appreciate having in your life?
I think it goes back to what we just talked about, passion. I've decided to only do things that I'm passionate about anymore. And my life revolves around dry eye, my family, and climbing boulders. And if it's not one of those things, I'm usually not doing it because those are the things that fuel my passion. And I just make sure that the time that I spend, any of my free time, it's doing things that I enjoy, that I like, that fuel my passion, that make me feel alive. And I don't worry. I don't worry about the other things.
This is a great theme. I feel like we're hearing this more and more, Jessilin, like do what you actually enjoy and then, cut out the other things. Like what's the point? Life is short, so do what you love.
Yeah.
It's so true.
Get
Words
one
to
shot
live
at
by.
it. That's it. Get one
That's
shot.
it. Mm-hmm. Yep.
That's great. Well, Jason, thank you so much for being here. You have been a tremendous guest. I've already learned so much, and I can't wait till we get to connect at the next conference. For our listeners who wanted to touch base with you or connect with you, how could they get in touch with you?
Yeah, feel free to email me. It's my name, Jason Besecker at gmail.com. You can look for me on the various social media things. I'm not that active on those. I wish I could say I was. I've tried. It's just very difficult for me. My personal one is Dry Eye Mechanic at Instagram. So that would be my personal one there. Yeah, but email is great.
Awesome. Perfect. Thank you so much. It was fun.
Yes. Thank
Oh,
you,
thank you. No,
Jason.
this was amazing. Thank you. And hopefully we can do it again. I will be looking for both of you when I'm at the conferences. I always do. I always look for my favorite people to at least connect for a few minutes. So
You're gonna be, if you're in Academy, you're gonna be in my hood. So
oh
you
yeah.
should
Yeah, I'll be
you should,
there for sure.
yeah. Okay, we'll connect.
Yeah, we'll definitely connect. Well, thank you again so much. It's been an honor.
Yes.
Thank you so much to both of you.
Thank you.